In Module 1, we will include discussion of different ways in which opioid use disorder can present. This is followed by a discussion of the risk factors for opioid use disorder and various validated screening tools that can be used to identify patients with opioid use disorder. There are many ways in which persons with substance use disorder present. The cases in this slide speak to the connection between prescription opioids and the opioid epidemic, contrasting concerning use with non-concerning use. Case 1 raises red flags, as this young man has pain lasting longer than expected after an injury. A pain medication dose, which has been increasing despite a benign, non-progressive condition, and evidence of opioid medicines from another physician by PMP, which is the Prescription Monitoring Program. This demonstrates a lack of control and increase in time spent pursuing pain medications. Case 2 does not raise red flags and does not suggest substance use disorder. However, it is still important to note that over time, physiologic tolerance and dependence will develop, and if the pain treatment is changed, the opioid must be carefully tapered off. There are adverse effects with long-term opioid use, so even with this patient's stable use as prescribed, we may still want to pursue other classes of pain medication and other modalities over time. Dr. Friedmann, can you describe the physiology of substance use disorder, the criteria for diagnosis, and screening tools you recommend?
I would be pleased to. So we'll be discussing today opioid use disorder, which is one of the members of the family of substance use disorders. And these disorders typically result from a process of behavioral conditioning in which, for example, in our case, opioids activate the reward areas of the brain, typically the ventral tegmental area and the nucleus accumbens. And this increased opioid activity leads to dopamine release. And dopamine is the main reward neurotransmitter. This increases in the nucleus accumbens and creates a good feeling. And these good feelings are part of our very basic survival. These are the things that lead us to eat, to reproduce. And typically, the brain remembers these good feelings created by the dopamine and desires to repeat behaviors again to try to get these same good feelings. Over time, exposure to these opioids creates long-lasting abnormalities in brain dopamine transporters. This slide happens to show the effects of methamphetamine, but the effects of opioids are very similar. You see these parts of the brain that we were referring to previously, the ventral tegmental area, the nucleus accumbens. And in a normal control on the left, you see there is a lot of red on this PET scan indicating a normal state of the brain dopamine transporters. What happens to people who've been exposed to chronic reinforcing compounds like methamphetamine or opioids is these transporters tend to be down regulated, which is what we see in the middle of the slide. After 1 month of detox, you see there's not a lot of red, so not a lot of dopamine being created. So this person is not feeling terribly well. And what we see on the right is after 24 months, those parts of the brain are starting to recover. So it really takes a very long time for people to come to a point where they start to feel normal. And these long-lasting abnormalities in the reward system really are a major explanation for the remitting and relapsing nature of the substance use disorder syndrome. The other part of the syndrome, which is unique in many ways to opioids, is the opioid withdrawal syndrome. So if we think of the reward as being positive reinforcement, it's the way I like to talk about it is if you think of a rat that has an IV in its tail and you train it to hit a lever and it gets the opioid or whatever the reinforcing compound is, it will continue to hit the lever until it dies. And what withdrawal is not a positive reinforcer, but it's what's called a negative reinforcer. So if you look at the bottom of this slide at this rat that's in a cage, and it's standing on an electrified grid, and if I turn on the electrified grid, and I know it's very cruel, but they do studies like this, and we drop the rat in it, it will sort of dance around like it has a hot foot until it, by accident, hits the lever, and then the electricity turns off. And the electricity turns on again, and it learns over time that if I hit the lever, that feeling of pain will go away. It's very different from punishment, in which a behavior creates an aversive. So opioid use disorder, in opioid use disorder, the withdrawal syndrome is a very prominent feature. It's excruciating. It's seen when people stop using opioids, or if we give them, if it's precipitated by giving them naloxone, which is Narcan, the reversal agent. But the way to think about withdrawal, and this is in the upper right part of this slide, is it really is, if you can imagine for a moment, the very worst flu that you've ever had, the upper respiratory infection. So you're achy, you're sweating, you're feeling terrible, you feel depressed. And then you combine that with the worst lower GI infection you've ever had. So you're having diarrhea and stomach cramps, and you're sort of curled up in a ball, just like the fellow in this drawing. And you have craving for the drug, and you have the knowledge in the back of your mind that if I just take a little bit of opioid, just a little bit, this misery will all go away very quickly. So that is a very powerful pull for folks to go back to using. And our patients who have this disorder spend much of their lives just trying to feel normal. You know, over time, people stop getting the rewarding effects and the high of it, and really they're just trying to avoid withdrawal. And often that's the time when they come and seek treatment. So these neurobehavioral manifestations are what create what DSM-V calls the substance use disorder syndrome. There are 11 features to the substance use disorder syndrome, and the severity of one's disorder is based on a count. 2 to 3 are mild, 4 to 5 moderate, greater than 6 severe. It's often difficult to think about all 11 categories, so I often divide them up into 4 parts. The first part being impaired control, which refers to requiring larger amounts or using for longer than the person intended. The second is about their inability to cut down, or desire to cut down, but inability to do so. This sort of speaks to their ability to control their use. Using a lot of time to obtain, use, or recover, and craving. The next feature is social impairment. Now, social impairment refers to how they function at work, home, or school. They continue to use despite having had problems in those areas and interpersonal problems, and also that they reduce their social, occupational, and recreational activities, and basically drug use becomes the only thing that they engage in. Risky use is using in dangerous circumstances, continued use despite having harms, particularly after overdose, we see folks continue to use. And finally, the physiologic manifestations of tolerance and withdrawal. Tolerance is requiring more to get the same effect, or getting less effect with the same amount. And with the withdrawal syndrome we talked about, and these physiologic manifestations, though they're important in the syndrome, you know, I encourage you in making the diagnosis for folks on chronic opioids, sort of downplay their significance, because folks on chronic opioids can manifest these physiologic manifestations.
I completely agree, Dr. Friedman. And patients that are safely using opioids to control severe daily pain will often have these symptoms you described because of dependence that develops physiologically. So I think when we're when we are trying to diagnose substance use disorder, opiate use disorder specifically, we really need to pay attention to the 4 C's, which is compulsive use, impaired control, continued use despite adverse consequences, and ongoing cravings.
Yes, it's those manifestations of impaired control, the sort of the compulsive quality of it. That really is what distinguishes it from legitimate opiate use for pain.
So as primary care providers, we are frontline evaluating and treating pain, especially chronic pain, and we cannot refrain from this treatment. However, being very cautious with opioid prescriptions is essential. Prior to writing an opioid prescription for acute or chronic pain, check the Prescription Drug Monitoring Program, or PDMP, looking for evidence of uncontrolled use. With severe acute pain requiring opioid pain medication, try to use the lowest effective dose of short-acting medication and limit the supply when possible to 3 days. Most acute pain is resolved within that time frame. With chronic pain, first try non-pharmacologic and non-opioid treatments. These are preferred given the risk of tolerance, dependence, and addiction with long-term opioid analgesic use, as well as other risks which I previously mentioned, ranging from opioid-induced hyperalgesia to overdose. Check the PDMP and screen for a history of substance use disorder. Address psychological comorbidities, social stressors, and lack of social support. And finally, it's very important to discuss realistic goals and create a treatment plan, which includes discontinuation of the opioid pain medication if there's no improvement in function, and use a pain medication agreement, which specifies for pill counts and urine toxicology screening.